please enjoy your Harborview egg salad sandwiches. Grab your chocolate chip cookies and come on and sit down and listen to a friend and a colleague whom I've been working with in the liver clinic for a number of years now, a long time. This is John Scott, who's a wonderful colleague and great to talk to in clinic, and he's going to be great to talk to you here. John Scott, MD, MSc, is an assistant professor of medicine in the Division of Allergy and Infectious Diseases at the University of Washington, and assistant director of the Hepatitis and Liver Clinic at Harborview. He graduated from Stanford University with a degree in human biology, attended Georgetown University School of Medicine cum laude, completed a residency in internal medicine at Stanford, and then obtained subspecialty training in infectious diseases at the University of Washington. He's a member of AOA and a former Howard Hughes Medical Institute research scholar. He has an active research program in viral hepatitis, which is supported by federal, foundation, and pharmaceutical grants. He is published in JAMA, Clinical Infectious Diseases, Annals of Internal Medicine, Nature Medicine, and the Journal of Infectious Diseases. In 2009, he launched Project ECHO in Washington State. This innovative telehealth program helps clinicians serving in rural and underserved areas with the evaluation and treatment of hepatitis C. And John is going to give us an update on hepatitis C and also what's important for us psychiatrists to know about this disease. Thank you.
Okay. Well, thanks a lot, Sharon. I don't know if you caught that Sharon and I actually overlapped at some point in our training. She was a plastic surgeon at Georgetown when I was a medical student there, so we reminisce about our days back in the nation's capital. So I just wanted to say thanks again for the invitation to speak to you. I work with a lot of you through the variety of projects that are going on, both research and clinical, so it's really exciting to speak to you. This is an especially auspicious time to talk about hepatitis C because things are changing so quickly, and I think that hopefully you'll be left with a sense of optimism that this is formerly incurable disease in the near future is going to be nearly curable with a pretty easy to take regimen. I think it's also appropriate that we're doing some broadcasting outside of our halls because I'm going to be talking about telehealth and how we can extend what's going on here at Harborview and the University of Washington to some of those rural areas that really don't have the resources that we're having here, and that's the Project ECHO telemedicine program that I've been working on. So I just wanted to give you an outline of what we're going to talk about today. Just give the basic basic overview of the epidemiology. What are the numbers we're talking about? Talk a little bit about the natural history. Talk about current therapy as of 2011, 2012. And give you an idea of where we're heading in the next couple of years. And finish up with two research projects. The first is a project called CHAMP that I worked with Jay Weikengruber on and has since been published, and then also talk about the telehealth program. So first of all, hepatitis C is a really common infection in the world and also in the United States. So based on an NHANES study, which was done several years ago, there's around 4 million people who are positive for hepatitis C antibodies. And this study was not done in certain high prevalence areas like prisons. So we think actually it's probably more like 7 million people who have hepatitis C. And I used to work in the Department of Corrections. It's around 30 to 35% of inmates, male inmates in Washington State are hep C positive. Sometimes as high as 40% in other states, and that's also a way that the virus is being transmitted. A lot of homemade tattoos that are being done in prison, so that's been a particular focus of mine, and trying to stop that transmission route. This is a disease of baby boomers, so the peak incidence is and prevalence is in the, and this is a little bit old, but around 40 to 60-year-old age group. So those folks who are born in the post-45 to 64 years, that's the highest prevalence. It's also a disease that seems to affect minorities more than Caucasians. So African Americans and Latinos have a prevalence that's about twice that in Caucasians. So this is really a bloodborne virus, with the most common risk factor being injection drug use. National data says it's around 60% of people with Hep C have injection drug use as a risk factor. Locally, it's probably around 80%. And it can be just 1 or 2 times that people are experimenting. I tell the story of one of our patients who came in for his initial evaluation, and we talked about how you get this. And he said, well, I know exactly when I got it. And he said, it was August 5th, 1969. I was at Woodstock. And I was 18-year-old and was drunk at the time, and someone was walking around with some syringes, and it seemed like a good idea to try it. And the only time he ever did injection drugs, and I got Hep C from it. So blood transfusion before 1992 is also a risk factor. We identified hepatitis C in 1989 and developed an antibody test. The blood supply became much safer after 92. Now, multiple sex partners is a little bit of an area of confusion and controversy. If you go back to the NHANES study that was done by the CDC, they found that if a person had more than 20 lifetime sex partners, then the risk of having hepatitis C goes up. But sometimes it's hard to sort out when in these retrospective studies, is that actually a co-risk factor with drug use that they're just not admitting to. So there have been some studies looking at discordant couples who are monogamous with each other, and the risk of transmission is very low, less than 1%. So what I tell my patients who are in that situation is actually the CDC doesn't recommend any change in protection. Is a very low risk of sexual transmission. So iatrogenic transmission does occur. There have been 2 pretty well publicized cases of iatrogenic exposure, one in Las Vegas where an endoscopy unit was reusing the single-use vials, trying to save $20 or $30, and they had 7 cases of transmission in that outbreak, and then a sad outbreak in Denver in which a nurse who was in the endoscopy unit was diverting fentanyl, injecting herself, and infected, again, about 6 patients. So that does happen. There's needle sticks, of course. Sadly, I see about 1 or 2 surgeons a year who get Hep C from the OR, usually in the setting of trauma or emergency surgery. Intranasal cocaine use also is a putative route of transmission. Piercing, tattooing, and ritual scarification can occur. I work with the Native American tribes, and there's a ritual called the Sundance Ritual where they young men, as part of their initiation into being a man, they'll do some ritual cutting, and in the past they used to use the same knife for that. So they've now been educated, and they have clean scalpels and only use it for one person. And with all that being said, about 10% of my patients, they have absolutely no risk factors for transmission. In particular, I have a lot of Vietnamese patients who, the one thing I can tell is maybe during the Vietnam War, they may have had some unsafe injection practices at that time. So this is an important slide that I like to draw out for all of my new patients, and this shows what happens to a typical patient. So if you took 100 patients, about 15 or even 20% of patients are able to fight off the infection. This is very different than HIV, whereas about 99% of people who get the antibodies for HIV, they'll go on to be truly infected and get AIDS. And we know now that this is highly correlated with one's genetic background, in particular region in chromosome 19 called IL-28. So if you are IL-28CC, you're much more likely to resolve the infection on your own. You're also more likely to respond to the treatment. And that is now a commercially available test that we can do here at the University of Washington. But for the vast majority of patients, they're going to be chronically infected. And it takes a long time before there's significant damage to the liver, on average 20 to 25 years before you're going to see something called cirrhosis. And we think about 20% of people a couple years ago would eventually get cirrhosis. But this is a slow process. So if a person got infected last year, it's very unlikely that they've had any significant damage. With that being said, there are certain things that really throw gasoline on the fire. The most important is alcohol. So what I tell my patients is that the combination of alcohol plus Hep C is really bad. It's not 1 + 1 = 2 in terms of hits your liver. It's like 1 + 1 = 4 or even 8. So if you have patients who are still struggling with alcohol addiction, probably the most important thing to address in that situation is a complete cessation of their alcohol. And we do require 6 months of sobriety before we'll consider treatment for that reason. There are certain other things besides alcohol that can accelerate it, HIV being probably the most prominent, but also hepatitis B co-infection. So once you develop cirrhosis, that's when bad things happen. So you have about a 6% chance of going on to end-stage liver disease each year. That would be when people get jaundice, big belly, bleeding, esophageal varices. They also have around a 4% risk annually of getting liver cancer. And liver cancer is the fastest growing cancer in the United States. It's doubled in the last 10 years, mostly because of hepatitis C. It's also got one of the worst survivals of any cancer out there. It's up there with some of the lung cancers. So 5-year survival is around 5%. So we want to obviously prevent the cirrhosis, and once they get cirrhosis, we want to screen for it annually. So we also do transplants here. Hep C is the most common reason for transplants. We've done over 1,000 liver transplants at the UW alone since the early 1990s. But there's a limited supply, unfortunately, of livers out there, so that's not a way that we can really accommodate the increase in end-stage liver disease. So part of the problem is that we're about to face a tsunami of complications from chronic hepatitis C. A lot of people got Hep C back in the 70s when they were experimenting with drugs, and now it's been the 20 to 25 years. So it's been ample time to get cirrhosis. So if you look at this, this is a mathematical model that was published in the Institute of Medicine report and presented to Congress. And if you look at where we were in 2009, there were around 50,000 people who had cirrhosis or the complications of cirrhosis, including liver cancer here in purple, decompensated cirrhosis here in appropriate jaundice color, and liver transplant in blue. But if you look in the next 10 years, what's going to happen is there's going to be a quadrupling of that number from around 50,000 to approaching 200,000. So we need to do something before it's too late. So one of the problems with hepatitis C is that very few people who have it are actually know that they have it. That's why we call it the stealth virus. And the most common symptom of hepatitis C is no symptoms at all, with the second most common being fatigue. You know how many people in primary care have fatigue? It's quite a number. So if you look at hepatitis C compared to HIV, it's about 4 times more common than HIV, and 50 to 75% of people with Hep C haven't had their diagnosis versus only 20% in HIV. So we've done a much better job with HIV. And in 2006, actually, there are more people dying from Hep C than HIV, and that's continued to expand. I think there's around 20,000 people in the latest year who have died from hepatitis C, whereas the HIV deaths have either plateaued or slowly going down. And very little spending has really been focused on this issue of screening. So 2% of the whole CDC budget is devoted to Hep B and Hep C versus around 70% for HIV. So just to let you know a little bit about some recent data to look at the cost effectiveness of hepatitis C screening. One was published by colleagues at the CDC, and then this other paper that will be coming out in Clinical Infectious Diseases was published by my fellow and myself. And both of the studies, in summary, found that it's extremely cost effective to do an age-based cohort approach. So anyone born between 1945 and 1964, a baby boomer, if you do a one-time screening, it's an incremental cost of around $3,000 per case identified. And just to give you kind of a ballpark of what we consider to be cost-effective is usually we use hemodialysis as an intervention, and right around $40,000 per quality. So this is massively cost-effective, and we found a very similar ICER of around $8,000. So our colleagues at the CDC, they found that if you're willing to spend around over $10,000 per patient identified than doing a one-time HbA1c screening and then getting them into PEG interferon ribavirin is cost effective. And then if you're willing to spend over $70,000, then it's effective to do the screening and use these newer drugs, the protease inhibitors. They're very expensive, around $50,000 to $60,000, which is why there's a big gap there. Part of the issue, though, is that the crisis is maturing, and there are fewer and fewer people who are in the early stages of their fibrosis, and more people are getting into advanced fibrosis. And what you can see is that it becomes less cost-effective as you get into more and more patients with cirrhosis. So we're kind of right here on the epidemic. So we probably should have done this intervention a couple of years ago. And so kind of the message I've been sounding to whoever will listen is that we need to do this now. It's going to be too late if we wait any longer. Part of the reason why I'm bringing this all up is that today the Agency for Health Research and Quality, HRQ, is going to release a report showing that there's no data showing that any kind of screening is cost effective, and they're going to probably come out saying that they don't recommend for any screening for hepatitis C. And the reason why they are saying this is because they're only using randomized clinical trials. They don't use these mathematical models and whatnot. And I think it's disappointing because there actually has not been any really RFAs out there to study this. And so it's been, I think, somewhat frustrating to have that position taken out there. And we're trying to work with them to at least come around a little bit on that. So remember that big curve that I showed you of what's going to happen? So Phil and I wanted to look at this and ask the question, what do we need to do to kind of reverse that huge peak of cases? And the bottom line is you got to do the screening, you got to get them into care, and then you have to offer them good therapy. And that's the only thing that's really going to drive it down from this peak of 35,000 deaths per year down to about 25,000. So it's still going to be there, but you got to do those three things to make a meaningful impact on this impending epidemic. So I'm going to transition from that kind of discouraging news to a little bit more hopeful news and just let you know that the therapy is fast evolving and give you an idea of the timeline of hepatitis C therapy. Back in the 90s, we used just standard interferon for 6 months, and we could only cure around 10% of those folks. And eventually went a little bit longer, started adding ribavirin. And for about 10 years, all we had was pegylated interferon ribavirin, and we were curing around 55% of all comers for that. So that's what we were working with for 10 years. And last year, in May of 2011, we had 2 new drugs approved. One's called boceprevir, the other one's called telaprevir. They're cousins, so they work in the same way. You would use one or the other. And there are protease inhibitors. So the way I explain this to my patients is they're kind of like laser-guided bombs. They're actually inhibiting a key enzyme that hepatitis C needs to replicate itself, whereas interferon ribavirin is much more nonspecific immune activation. And we're seeing cure rates now over 70% for genotype 1 patients, and our genotype 2s and 3s already have cure rates over 70%. So the take-home message is for the vast majority of patients, it's curable in over 70% of them. Now, you may be aware of some of those side effects because you probably have seen some of these people. And if you came to my clinic this morning, you might see 1 or 2 people like this who are a little bit irritable. Interferon has a lot of psychiatric side effects, including irritability, insomnia, depression. Also, I've seen some manic episodes with it. In addition to that, it's a bone marrow suppressing agent, so cytopenias are another thing that we need to follow. Rashes can sometimes be a problem. And this is just an expensive therapy, so around $20,000 to $70,000 for this course of therapy. The good news is that around 20% of the people have a very easily treated form of hepatitis C. They're genotype 2s and 3s. We can use a lower dose of the ribavirin, and I would get cure rates in the 70 to 80% range, and that's pretty cheap, $20,000 for that. So I like to call the genotype 2s and 3s the low-hanging fruit. And if you have those people in your clinic, that would be someone I probably would be most interested in seeing. So I'm going to talk about some of these newer therapies and give you an idea of where we're targeting these new agents. So hepatitis C is a single-stranded RNA virus. It binds to the cell receptor. There's a variety of cells that it targets. Obviously the liver cell, but there's also B cells that can be targeted. So some patients can get lymphoma as a result of their hepatitis C. But anyway, it gets mostly into the hepatocyte, and there's a fusion and encoding process. And then translation and polyprotein processing occurs fairly early in the process, and this is where the new agents are working. You'll hear later on in my talk about a target right here in the process of RNA replication. Those are polymerase inhibitors. So just like in HIV, we're targeting different parts of the life cycle. That's what we're using the same approach for hepatitis C. So hepatitis C is a pretty small virus in terms of viruses that infect man. It's around 9.6 kilobases. And when it gets replicated, it forms a polyprotein. It kind of looks like a long log. And for the hepatitis C to assemble into a three-dimensional structure, you need kind of a chainsaw to cut up that log into smaller pieces. And that chainsaw, that molecular chainsaw, is called a serine protease. And that's actually what we're targeting with these new drugs. So it's gumming up this chainsaw, to give you a different analogy there. This is the active binding site. It's actually, when I talk to the people who developed this drug, it's a pretty hard target to get into from a three-dimensional perspective. They say it was like trying to land a paper airplane on a greasy pizza. Was actually the way they described it. Just kind of hard to get in that binding site there. So I'm going to talk about some of the pivotal clinical trials. Most of these were published in the New England Journal in the last year. This one is from Telaprevir, called the ADVANCE trial. And you can see we went from a cure rate of 44% with the standard of care PEG-RIBA up to around 75%. That's the largest kind of jump we've seen in hepatitis C therapy. So a huge bump there. And a lot of the reason why it worked is we had fewer people relapsing. So instead of about 1 in 3, 1 in 4 people relapsing, it was around 1 in 10. And so these people are taking 12 weeks of Telaprevir plus PEG, interferon, and ribavirin. You stop the Telaprevir, and then you continue with the PEG, ribavirin for anywhere from another 12 to another 36 weeks. So we can get by with a little bit shorter course in about 60% of our patients. That's the other bit of news. So the way I frame this to my patients is we're almost doubling the cure rate, and in a lot of cases we're halving the treatment time, which that's a pretty good deal. Now, I just want to let you know where we're going with these newer drugs. The Telaprevir is great. You saw the cure rates, but it has a lot of side effects like rash. So I've had some people get a really bad hives to the point where they had to stop. Rectal itching and burning. We see some pretty significant anemias, people dropping their crit by half in 1 month. So it's not without its side effects. And so we're trying to get a therapy that is a little bit easier to take. You also have to take this drug 3 times a day with fat, and that's sometimes hard for some of my patients. The other thing that we're trying to get away was the interferon. Remember interferon man? That's the big bad drug, and because so many of our patients have psychiatric issues, a lot of times that's the rate-limiting step and is preventing a lot of our patients from getting treated. So we're really trying to get away from interferon-free, or get away from interferon. We're also looking for drugs that have a high barrier to resistance. We'd like drugs that get all the different genotypes, not just genotype 1. It'd be great if we could get short duration, 12 weeks, and a high cure rate. So really what I'm looking for is something like Atripla, which we have for HIV. It's 3 pills, co-formulated into one little pill. And it's easy to take, has a pretty good side effect profile. And so I've coined this pill the Hep Slayer pill. And I think it's coming out in a couple of years. It's just a matter of what's going to be in that combination. But this is really what we're hoping to get. So in terms of the drug development strategy, there's 2 parallel streams going on. One is with interferon-containing regimens, so-called quad regimens. So they got interferon, ribavirin plus 2 new drugs. And then there's the interferon-free regimens. And each of those kind of have their pros and cons. So I wanted to talk to you a little bit about the interferon-free, since that's probably where a lot of the buzz is and what a lot of people are talking about. The first proof of concept study was the so-called INFORM-1 study, which was published in Lancet about a year ago. And this was with a polymerase inhibitor by Roche Genentech. Its trade name is miracytabine, and they also had a protease inhibitor. So it's just those two drugs. They treated 74 patients and had a very nice decline in the viral load. We still don't have any long-term data on these patients, though, but it was the first kind of proof of concept. I just wanted to give you results of a preliminary trial that was presented at the International Liver Meeting about 2 months ago in San Francisco. It's called the Electron trial. This is for people who are genotype 2 and 3, and they're treatment naive. And there were 4 different arms. You can see the top 3 arms had some kind of interferon in it, and the last arm here was just with an oral polymerase inhibitor that is very well tolerated. It's once a day, and ribavirin for 12 weeks. And what you can see here is that there's a lot of 100% here, is that almost everyone got cured with this regimen, including this regimen right here, which was just the 12 weeks of a oral polymerase inhibitor and ribavirin. And so if you can imagine 4,000 people packed in an auditorium and just a collective gasp. I mean, it was I've never been in such a large room and people just, their jaws open. And lots of people taking pictures of this. So this drug is made by Pharmasset. And on basis of this, Gilead actually paid $11 billion for Pharmasset. So I think this is kind of the buzz on the street is drugs like this we're looking for. And they're probably another 2 or 3 years out from getting to the clinic. So this is kind of where we are in 2012, interferon, ribavirin, and a polymerase inhibitor. We're talking about a 70% cure rate. In 2 years, we'll probably have the polymerase inhibitors and even better protease inhibitors. I don't see interferon and ribavirin going away anytime soon. So we're still going to need our psychiatrists' help managing a lot of these psychiatric patients and making sure they don't get too depressed. But eventually, in another 3 to 4 years, I think we'll be dropping that interferon and hopefully getting a much higher cure rate. So I'm going to transition to the last part of my talk to talking about some research that we've been doing. This was a project that I worked with Jay on a couple of years ago. And we were looking at some of the issues related to interferon treatment, in particular in the X injection drug users. This was a study that was sponsored by the CHAMP program here. And the reason why it's important is that Hep C is very common in X injection drug users, 50 to 90%. And also depression is very common in X IDUs, maybe as high as 85%. So those 3 issues kind of travel together. And the diagnostic tools for depression are not all that great. And part of the problem is there's a lot of somatic symptoms with Hep C. As I said, the most common symptom of Hep C is no symptom, but the second common is fatigue. And that's part of a lot of the BDI and PHQ-9. So we're trying to sort that out. And it's also one of the most common reasons for why treatment is not undertaken, is just there's so much psychiatric comorbidity. So the specific aims of this study were to determine the prevalence of mild, moderate, and severe depression using both the BDI and the PHQ-9. We then wanted to look at the prevalence of PTSD, and this was something that Karina Udall had suggested because her hypothesis was that patients with PTSD have a harder time bonding with their clinician, and there might be some issues with trust and adherence by extension of that. We then wanted to look at the screening instruments compared to a gold standard, which is a psychiatric exam by Dr. Weitengruber, and then look at if baseline depression would correspond with actual treatment outcomes and adherence. So this is the baseline results of how common depression was. You can see the vast majority of people, whether you're looking at the PHQ-9 or the BDI, had some kind of depression, with almost 20% reporting severe depression. And the BDI and the PHQ-9 correlated quite well with an R of 0.71. So there's quite a bit of overlap in the two studies, or the two instruments. When you look at the PHQ-9 and the BDI compared to the gold standard, the mini exam, there were quite a number of folks who were coming out as depressed using these short questionnaires, but when Jay examined them, they actually did not meet criteria for depression. So there's what we call high false positivity in there. So 9 out of 30 were false positive, and 12 out of 30 with the PHQ-9. So then we wanted to look at the receiver operating curve to see if there's some kind of a cutoff with the BDI and PHQ-9 in which we can say this is a better cutoff for depression, and a BDI score of 31 gave us the maximum sensitivity and specificity, and a cutoff of 14 gave us the maximum sensitivity and specificity if we had the PHQ-9. So some other interesting findings is that over 50% of our patients met criteria for PTSD. Over 25% had some history of a suicide attempt. And I just want to give you a perspective. These are people who had already been screened by their primary care doctor and referred to me. So these are not just all comers coming through, through the SCD clinic or in the general population. There was at least some kind of initial screening. Despite all that, despite all the psychiatric comorbidity and kind of social upheaval in these people's lives, they actually do pretty well. So adherence was over 95%. And I think that really speaks to the kind of wraparound service that we're able to provide with having the psychiatrists here involved so intimately. And I have to tell you, what we have here is very unique. When I go and speak nationally and even regionally, and I tell them that I have someone like Sharon Rahm or Jay or Simon Livingston to see these people, they just shake their heads and say, that's unbelievable. So I just wanted to say thanks again for helping us out, because this is really increasing the access to this therapy and improving their chance of getting cured. So the conclusions are that there's a lot of psychiatric comorbidity in our patients here at Harborview in the injection drug population. Despite all that, if you give them enough support, including fairly regular psychiatric follow-up, they have great adherence. And both the BDI and PHQ-9 probably overdiagnosed depression. So my recommendation to folks is that if you get a high score, don't use that as the last say in the subject. You probably want to refer them to psychiatrists to get a more definitive opinion. And I think in some situations you might be able to get these people treated. So in the last part of my talk, I'm going to talk about how do you do Hep C care outside of Seattle and outside of the UW, because this is a problem that's not confined to urban areas. In fact, if you go to some very remote areas in the Pacific Northwest, there's a very high prevalence. And the way I learned this was about 4 years ago. I was asked to give a talk on Hep C in Havre, Montana, which is about 10-15 miles from the Canadian border, kind of in the central part of the state of Montana. And it was a cold January night. It was like 20 degrees, and I thought I'd have like 2 people sitting in the first row, but actually you had about 80 people come out. And they said this is a huge problem in our community. Really, I think was a reflection of the methamphetamine epidemic at that time. And they said because of the geographic barriers, because of some of the insurance issues, very few of these people were getting treated. And it was to the point where they were feeling hopeless, and they stopped screening. So that got me thinking at that time about a way to help these people. And I was trying to email them and even have them come out here and shadow me, and that didn't really work. And about that time, I heard about a guy named Sanjeev Arora who had a similar problem in New Mexico, which was even more rural than Washington State and our WAMI region. And he had devised a telehealth project called Project Echo to address this problem. And I'm going to tell you a little bit about that. But some of the issues that we face are the geographic barriers. We have some lovely mountains here, but if you're on interferon treatment, it's not really all that great to be driving over Blewett Pass and then Snoqualmie Pass, when there's 10 inches of snow and you're on interferon. Also insurance barriers. So 50% of patients with Hep C have no insurance whatsoever nationally. And I know of practices in the country where they'll only take you if you pay cash or you have commercial insurance. They won't even take Medicaid. Can't even get an appointment. So even if you can make that drive over the pass, sometimes the specialists who know how to treat Hep C won't even take these patients. And then the last issue is that even if you can see a specialist, it's sometimes months. In Dr. Rohr's case, his wait list was 9 months, and a couple of years ago, our wait list was around 3 to 4 months, and we've been able to shorten that. So what Project ECHO does is it's a case conference. To kind of explain it in a really shorthand way, this is kind of like morning report. I'm an internist by training. What we would do is we'd be on call when we were residents, and you'd take 10, 20 admissions, and the next day you come in blurry-eyed and present to your colleagues and also to the attendings. And you would get opinion on your workup and to think about the case more completely. And that's exactly what we're trying to do with this. We have rural doctors who are joined by televideo, and they're presenting actual patients to a variety of specialists. So in Hep C, it's myself, Dr. Schuhart, who's a hepatologist, and then Stanley Shen, and we have Joe Merrill as well. This is the back of Joe's head here. So we have patients who have addiction medicine problems, who have psychiatric problems. They can get a comprehensive opinion. This is Christina Udels Flores, who helps out with our Friday clinic on addiction and medicine problems. So we can go through about 10 or 15 cases over the course of an hour. I think we just set a record last Tuesday. We went through 19 cases in 1 hour. We were flying through them. We also have a 10 to 15 minute didactic on issues affecting hepatitis C. So we might talk about screening 1 week. We might talk about a common side effect with the therapy. Last week, Stanley talked about schizophrenia and how to diagnose it and epidemiology. So they're getting didactic. They get no-cost CME for their time. And we have a written report that we fax to them within 24 hours. And we're able to follow these people longitudinally. So they present the patient. We say, okay, we think this person needs a liver biopsy. Or, no, they don't need a liver biopsy. Let's go ahead and treat them. And if any problems arise, they can see us every week, and we can help manage them through those side effects. The other thing goes on is that there are other people listening. So while one doctor is presenting, there are 5 to 10 other people throughout the Pacific Northwest are hearing about this, and common things occur commonly. So they learn from their colleagues. Sometimes even the rural doctors know what it's like to practice in that situation, so they help their colleagues out and say, well, I know what it's like, and this is what I did in working in a very similar situation. So they teach us as well what it's like to practice in a resource-limited setting. So there are really 4 foundations of Project ECHO. The first is that we use telehealth to leverage scarce healthcare resources. So the patient doesn't have to travel, the doctor doesn't have to travel. We use disease management with best practices. So we're not doing anything experimental here. We're just trying to use evidence-based guidelines. And this is where having a colleague like Dr. Schuhart, who actually wrote the expert opinion for hepatitis C care, is really helpful. So he knows the data and can bring that to bear and really giving excellent care. This is case-based learning. We know that from work by Alba Endura and others that as adults we learn best when we can hang a concept on an actual patient and you can apply it right then and there. It's a very effective way of teaching adults, and they always have that lifeline, that backup if they run into any problems. And then the last thing is we want to make sure we're doing this safely. So we measure outcomes through a HIPAA-compliant database. So some of the benefits to the patients are they don't have to travel. So that means they don't have to take off from work. They don't need to pay for child care. They're staying in their community, and the docs in the community know what the local culture is and can provide culturally competent care. They're also much more integrated into a medical home. So I don't know about you guys, but sometimes when I get a referral, I don't have all the medications. Since we're keeping all the care actually with the primary care doctor, there's less of that issue of data transfer. It's also promoting prompt care, treating it before the patient gets cirrhosis, and there's also improved quality. I want to tell you a little bit about data supporting that claim that there's improved quality. This is a study that was published in the June 6th version of the New England Journal of Medicine. Dr. Roy was the lead author. is a prospective cohort trial that compared the safety and efficacy of hepatitis C treatment through Project ECHO into these rural sites versus his own practice at the University of New Mexico. He treated all genotypes. These patients were treatment naive. They used the same protocol through Project ECHO versus in his own practice. They used both forms of interferon, the alpha 2A and 2B in ribavirin. This was conducted from the period of 2003 to 2008. There were 21 rural sites and prisons, and they did the comparator was the hepatology clinic at the University of New Mexico. So I wanted to point out a couple of baseline differences here, which are relevant to talk about. Obviously, we couldn't randomize the patients here. So the first is that there are younger patients in the Project ECHO sites. So on average, around 42 versus 45. That would tend to benefit ECHO sites. So younger people do better with the therapy. The next one is that there were more men in the ECHO sites because they were prisons that they were treating. Now that would actually favor the University of New Mexico site because women actually do better than men. The other issue is there's way more Latinos in the ECHO sites, so almost 2/3 of the patients were Latinos. They do not respond as well to therapy. So again, that would favor the New Mexico site. And the last issue is that the patients in the ECHO sites tend to be heavier, on average 5 kilos heavier. That again would favor the New Mexico patients. So of these four that were different, 3 of them would tend to favor the University of New Mexico. I just wanted to give that context when you see the results. So if you look at the cure rate, they're almost exactly the same. So this is a sustained viral response, 57.5% in Albuquerque versus 58.2%, actually a little bit better. And if you break it down by genotypes, within 2 to 3% of each other, but not statistically significant. So it's just as effective using Project ECHO as seeing the so-called expert in academic medical center. You might be interested in the safety. Actually, it seems like it's safer in the ECHO site. So SAEs were 7% in ECHO versus 14% at the University of New Mexico. So part of the reason why I was curious about this, what's different in the rural sites, and I asked one of our participating docs about this, and he said, John, it's really easy. I mean, if you screw up in a small community, you're going to see that patient at the grocery store the next day, or you're going to see him at your kid's basketball game. So you tend to be a little bit more conservative in a small town community. You really want to make sure you're doing things safely. Whether that's true or not, I don't know, but that's just one perspective. So the conclusions are that treatment by primary care doctors via Project ECHO is just as safe and effective as treatment by specialists. I also want to let you know that this is the highest cure rate ever reported. It's higher than the randomized clinical trials, which were in the low 50s. So best practices, using that multi-specialty integrated support with the primary care doctor intimately involved, seems to be the best way of doing this. And the last thing is we're talking a lot about health disparities these days, and I'm not aware of too many programs that have actually reversed a health disparity. This program did. The Latinos did just as well as Caucasians in this study. So we've been doing this for about coming up on our 3rd year, and these are some of our participants. And I'll just let you know some of the things that they have said about it. One doc said, I'm involved to learn more effective and safe treatment practices to provide treatment for my Hep C patients in the community. Specialty care is more than an hour away and patients have transportation issues. This is Dr. Grant who said this, and she said, sometimes patients don't even have a car that's running. That's the issue. It's a very fundamental issue. Another doc said the most beneficial component is educating myself and getting education in evaluating and treating. And this is really an interesting point, is that we've seen docs get benefit not just on their Hep C patients, but on their patients who have psychiatric problems. So one doctor said, Project ECHO helps me be more scientific in my approach to psychiatric problems. And I just wanted to let you know that your colleague, Dr. Shin, is doing such a wonderful job. So many people have come up and told me how much they appreciate all of his help. We had this one gal who Stanley just made one little tweak in her medications, and the doc said the patient has never felt this well in her whole life. She didn't even think she could feel this well. And this is when she had hematocrit of like 25. So sometimes making just that one little tweak can make all the difference in the world. And then the last thing that docs are saying is that this is a fun thing to do, that they're enjoying the camaraderie. There's less social isolation. So we started this with Hep C, and as we went out to the communities and to do follow-up and talk to them, they said, John, this is great, but what we really need help on is addictions and chronic pain. Can you do something for that? So in collaboration with Roger Rosenblatt in family medicine, John Roll at Washington State University, Alex Kahana and David Talbot in anesthesia pain medicine, we have launched 2 new echoes, one in chronic pain, which started about 9 months ago, and one in what we call integrated addiction and psychiatry. That was over a year ago. And you can see that it's just been growing by leaps and bounds. We've trained over 130 clinicians on chronic pain management and over 117 in the integrated addiction and psychiatry. And a lot of these people are learning how to use buprenorphine for opioid addiction. So of these, about I think 100 actually have their waiver now, a certificate. So this is, I don't know if you can see this, but this is where we are as of about 3 months ago. It's grown by another 10 sites since then. But just to point out, we're as far out west and north as Nome, Alaska, and St. Lawrence Island, which is literally, I think, a couple miles from Russia. And we're out east as far as Missoula and Whitefish. And I'm happy to say that, remember that site I told you about in Havre, they're actually going to be joining us in February. It's actually a former doc who was in Missoula, and she has moved up to Havre. So we're going to have someone out there. We're even down to the Oregon-California border. So part of the challenge actually is we're in 3 different time zones. So sometimes we have to start a little bit early and end a little bit late to accommodate different schedules there. To give you an idea where we are in Washington State, we're in over half of the counties. We've got a couple of gaps here. We're trying to hit southeastern Washington. We do have a new site in Vancouver, Washington. The CMAR Clinic has just joined us last week. And we do have a site here out on the peninsula with Shoalwater Bay, who's joined us. So basically, you're within about an hour drive of one of these echo sites. And I just want to let you know, next week we're going to have our first Project Echo for HIV. We got a grant from HRSA to be doing that. We have 10 new sites, and we're really excited to be working with folks in the Madison Clinic on that. So I just wanted to end with a word of thanks to all the people who have helped me out. The CHAMP project was a nice project. We worked with Jay and Peter Royburn. And Project Echo, we've been working closely with Stanley Shen, Christina Udalls-Forrest, and Karina Udall. So I'm happy to take any questions at this point. Any questions? Yeah, Sharon in the back.
Yes. Could you tell us, could you alert us to some of the symptoms, psychiatric symptoms especially, that patients would have with as yet undiagnosed hepatitis C?
Okay. So the question for the folks who are listening out there is, what are some of the symptoms, especially the psychiatric symptoms you might see with undiagnosed Hep C? Sharon, the most common thing that I've seen is kind of what I call a brain fog. And in fact, I think we shared a patient in common who was a carpenter who he just couldn't do the calculations anymore, just the rudimentary calculations. And so I've seen that. Sometimes fatigue can overlap quite a bit with depression. So it's pretty nonspecific, really, and which is why we wanted to have a little simpler screening for these people. But aside from that, there aren't really telltale psychiatric symptoms. Jay?
The Project Echo data looks great. How do you see funding that in the future after the grants are
So the question from Jay was, what's the financial sustainability look like? And that's the $1 million question. So in New Mexico, the state legislature has supported it. Medicaid is now paying Echo $300 per consultation to the academic medical center, and another $50 to $100 to the originating site. And really, at this step, we're trying to convince the third-party payers of the return on investment, and so we're submitting a grant to do that. Really, what is the health economic benefit? We're, as you can see, we're trying to target some really common, complex chronic diseases that account for a lot of healthcare spending. We want to target people who are dual Medicare and Medicaid, because we know they account for disproportionate spending healthcare dollars. And we're at this point, we're trying to just convince the third-party payers of this benefit and come up with a plan. But in the next couple of years, that's when I want to be doing this. We would know the patient's name, we'd build a third-party payer, and go from there. L&I is already reimbursing us for our chronic pain. They pay us $300 per consultation. They have an RVU code and everything. So that's really the cutting edge and where I'm spending a lot of my time to keep this going beyond grants. Yeah.
Even online.
Yep. Did you want this one? Okay. I think they wanted that. Any other questions? Okay, well, I just want to make an open invitation. If you ever want to see Project Echo in action, we're over in NJB on the 12th floor. Or you can talk to Stanley or Christina and kind of get their feedback on how it works. I love working with the Department of Psychiatry. If I could pick one person for any Project Echo, it would be my psychiatrist. It would be the first person I would hire, because the feedback has been so positive. There's a real need for quality psychiatric care in rural areas. So it's great working with you all.
John, thank you,
Yeah.
and I hope that you'll come back and give us an update
Okay.
on your project.
Okay, great. Thank you very much.